Hello and welcome to Office Hours, where I answer your questions about weight and weight medication. I'm Dr. Meghan. I'm a board certified physician in internal medicine, lifestyle medicine, and obesity medicine. And this is really important because I actually prescribe these medications all the time. I actually talk to patients about their weight all the time. I've helped hundreds of patients lose weight, and I'm here to help you too. So if you're confused about your weight, if you have questions about weight medication, and if you want medically based answers to your weight questions, you are in the right place. So today I am answering your questions about weight and weight medication. And then for all of January, I'm doing an added daily shorts bonus question. So if you have questions after this, you can feel free to leave them on this video, on another video, and I will get to as many as I can. So thank you all for sending them in. They have been great. And always, as a disclaimer, I can't answer personal medical questions because I'm not your personal doctor. So if your question does lean a little personal, I'm going to change it slightly so it's more broadly educationally appropriate and applicable. So let's get started. So this first section is two separate questions. You guys want to talk about this a lot. Okay, first comment. My nurse had 4 patients with gastroparesis in 1 week. I was the only one not on weight loss shots. Then the second one is a bit long, so I'm going to shorten it a little bit. I have type 2 diabetes with an average A1C of 12 to 14 for the past 14 years. I started Mounjaro 2.5 in November. First month was fine, no issues. As soon as I titrated to 5, the food sat in my stomach for nearly 4 days. Okay, so basically this question, I'm going to shorten this, goes on to say, this person was just having a lot of trouble eating and drinking when they went up to the 5 milligrams of Mounjaro, and they do have diabetes. So after speaking to my GP, primary care doctor, I'm going to retry 2.5 next week, see how I get on. It might be that I have nerve damage already, and that's why I responded so poorly to Mounjaro, but I have no history of gastric issues before. So I do think, yes, gastroparesis can happen, hopefully rarely. So 2 questions. Actually, there's a lot more than 2 that you guys send me about this, but you all really want to talk about gastroparesis, and I get it. I totally get it. I'm very aware of gastroparesis, but you all want to talk about it, and so let's just take the opportunity to talk more about it. So gastroparesis, I think, gets overrepresented in the media in terms of how common it is. Gastroparesis essentially is when the food in your GI tract, but more specifically the food in your stomach, is not moving really at all. So that whole idea of like stomach paralysis. And there is, if you think of gastroparesis on a spectrum of the speed of which food is moving through the stomach, with gastroparesis being on the very severe and kind of like end stage, in the same way that a bowel obstruction would be end stage of movement of the food through the intestines, gastroparesis would be the end stage, the most severe complication you could have in terms of the movement of food through the stomach. But there's a lot of gray area in between. So there's, regular movement of the food. Some people even have rapid gastric emptying. And so in those cases, these medications are extra effective for them because the food moves too quickly. But so what happens with the GLP-1 medications, part of the way that they work is they slow down the movement of food through the stomach. And they also can slow down the movement of food through the rest of the GI tract. But the movement of food through the stomach is one of the main mechanisms in how they work. And so this can be extremely helpful for a lot of people because they're feeling their fullness a lot more. So whereas before, they're kind of missing those cues from the stomach to the brain, now that signal is much, much stronger and it's much harder to ignore. So that is one of the main ways that the medications work, is helping you feel full for sooner and for longer. But as always, these medications are not appropriate for everybody. And there's going to be some people who have side effects. And some people are going to have like the worst side effects. And so this is also a very important reason why not everybody should be on these medications. Whoever's prescribing these medications really needs to take the time to accurately assess whether the patient is an appropriate candidate. So if somebody has issues with gastroparesis before, there's a higher risk they're going to probably have issues with it on the medication. And if somebody has diabetes, you are more prone to gastroparesis in general because of the nerve damage that can happen with diabetes as it progresses. And that can be there's many different types of nerve damage that can happen with diabetes, but one of the places that can be really affected is the stomach. In general, in my clinic, I don't really see a lot of gastroparesis because those people I'm not going to start on the medication, or if they do have a lot of nausea or a lot of vomiting or something I'm really concerned about, I'm going to start them very, very slowly. And it's not to say that these things never happen, but you just have to be, anybody prescribing these medications has to be very careful. All this is to say that gastroparesis definitely happens. It's rare, or it should be rare. Now, if it's not rare, that's because it's not being prescribed appropriately. This is also another great time, another great teaching moment to really let everybody know that you need to be monitored on these medications. This should not be like a drive-through situation where you text and somebody sends you something and you never talk to a human and you're never being monitored, and you get something in the mail and you don't even know what it is, but it says tirzepatide on it. Like, that's not a great situation for somebody's safety, okay? So buyer beware. And I've made a lot of videos about safe prescribing and things like that. Again, you really need to be talking to a human being who is appropriately trained to monitor you and prescribe these medications for you, and that you have a plan for what happens if something goes wrong. And that's that's for any of these conditions. But gastroparesis should be pretty rare. And if it's not rare, it's really more of a problem with patient selection and not so much the medication, because it's part of how the medications work. They shouldn't be causing paralysis, but they do slow the movement of food. So some people are not going to be the best fit. And then I also think that this, stomach paralysis is a very newsworthy term. So it definitely gets picked up more often and sensationalized in, the media. So anyway, you guys love to talk about this. And if you want to talk more about it, we can definitely do that. Let me know. So anyway, don't get this stuff from a computer and nobody ever checks on you. That's not a good idea. Next question. All right. Thank you for doing this. I'm thinking of taking Mounjaro. I have lipedema, stage 3, and obesity. My joints and mobility are suffering. I've tried every weight loss, going to no effect. I don't have a gallbladder. I have IBS and hiatal hernia. I'm concerned about side effects or if I can even take it. Any advice help? Greatly appreciated. Okay, so I'm going to change this a little bit so it's not quite so personal, but and let me know if you all would like me to do a longer video on lipedema. Because it is different from obesity. So I'm happy to do that and do more of a deep dive into this. But essentially, lipedema is a fat distribution disorder. There's an imbalance of fat that is deposited in the lower extremities, in the lower legs. And more so, then it's not like evenly distributed across the body like it is often in obesity, but it is, there's an imbalance of fat that's deposited in the legs. And when that and it's not really a problem unless somebody's BMI gets higher. Like if somebody has a lower BMI, it might, it's not clinically going to be maybe much of an issue for them, but as their BMI gets higher, it's going to have more and more of an effect. And then it can also cause issues with swelling and lymphatic drainage. And that's where the it's kind of a misnomer. It's not that it's edema as the primary problem or the fluid is the primary problem. It's more that the weight gain, the fat that's the imbalance of fat and more of it can then interfere with other things in the lower legs, like the lymphatic drainage, and then that can cause swelling on top of the fat that's already there and causing discomfort, joint problems, things like that. So it can really be kind of a vicious cycle. But I would say, if I have a patient who has lipedema, the primary goal is weight loss because that's going to improve a lot of the symptoms anyway. So I'm definitely going to be assessing them to see if they are an appropriate candidate for a GLP-1 receptor agonist, because a lot of times that can be extremely helpful. So I'm definitely putting it right at the top of my list for a potential treatment for somebody. Next, that is a great question. Next question. Which would you suggest is the safest medication to take? With my Mounjaro 15 milligrams, I've lost 76 pounds. That's amazing. Congratulations so far, but I'm still in the overweight range, even though I weigh 150. I would like to lose 20 pounds. I have started back on metformin for a while, but it doesn't work for me. I'll talk to my doctor about something else. I'm just not too sure about the weight loss pills. I'm 69. I wondered what you would consider safe. Okay. So essentially, what the gist of this question is, this person is maxed out on their Mounjaro. They still want to lose more weight. It sounds like they and their doctor feel like they could be a safer, a lower BMI would be medically safer for them. Metformin doesn't really work for them, and they are, their age is 69. So, yeah, I think certainly if I had somebody I have a lot of people in this situation, and sometimes the oral medications adding those can be a really good option to add on top of the Mounjaro, and it really just comes down to comes down to a lot of things. Of course, it depends on the patient, but one of the main questions is what are the other primary medical issues that this patient has, because that really directs what you can use. So if they also have AFib, I'm not going to add phentermine or Contrave. So, maybe I'm thinking about something like topiramate. Maybe I'm thinking about trying the metformin in a different way. But I would say the oral medications can be a really good option to add on, but it really just depends on what else somebody is working with in terms of their medical issues. I also don't always love starting a stimulant medication in someone who's in their 60s, 70s. Sometimes it's the right fit for a patient, not always. The other thing is, this is a great time to think about, is this person maxed out on their lifestyle changes, right? Because even medications, if we add them, we're doing them forever, right? And so we might as well think about the lifestyle changes, because as we change those, we're also doing them forever. Just like medications, if you go to the gym for 6 months and then you stop going to the gym, it doesn't continue to work. So anything you add, you want to think about through the lens of doing it forever. So if somebody is 20 pounds away from their goal BMI, that is also a really good time to think about, you know, is this person really doing everything they can do to, in terms of the lifestyle changes? And if not, where are the gaps? Because the nice thing about lifestyle changes is you don't have to fight with insurance companies. It's 100% under your control. And more often than not, you feel way better after you make them. So they're usually safer, they have less side effects, you're 100% in control, and you feel better. So that's the other thing that I would be thinking about. Like if this person is very close to they're 20 pounds away from their weight, but they don't exercise, I would add that in first and really figure out a way to make that fit for that person. Are they eating exactly how they want to eat? And if not, what would they change to really get that to where they want to be? So that would really be my first go to, and then thinking about other medications as well. It's not as easy as prescribing something, but the medications always work so much better when you are adding in the lifestyle changes as well. Also, another thing to think about are, okay, where are the gaps, right? And it might be that for some people, they're in this situation and they're already doing everything that they want to be doing and they're dialed in on their lifestyle changes, and that's great. And that really gives you a good idea of like, okay, well then medication is the next place to go. But it does give me some direction as their doctor in terms of the next best step for them. So what a great question. Thank you so much. So if you have questions after this, please leave them on the video. I'm going to get to as many as possible for January. Go ahead and subscribe to my channel. It's the place for medically based answers to your weight questions. And if you want to work with me directly, I do work one-on-one with people around the world to help them with the non-medical aspects of their weight loss as well. I will leave that info down below. Thank you so much for watching, and please be well.